Welcome to our comprehensive review of kyphoplasty outcomes for osteoporotic compression fractures in the thoracic and lumbar spine. Kyphoplasty is a minimally invasive procedure designed to restore vertebral height and relieve pain in patients with vertebral compression fractures, most commonly caused by osteoporosis. With an aging population, the incidence of these fractures is on the rise, making effective treatment strategies increasingly important. In this video, we'll explore the differences in clinical outcomes between the thoracic and lumbar regions, discuss the methodology behind the latest systematic review and meta-analysis, and highlight what these findings mean for patients and clinicians alike. Might wonder why it's important to distinguish between thoracic and lumbar spine fractures when analyzing kyphoplasty outcomes. The thoracic and lumbar regions differ significantly in anatomy and biomechanics, which can influence both the manifestation of symptoms and the effectiveness of treatments. Historically, studies have often grouped these regions together, potentially overlooking critical differences. By comparing outcomes based on spinal location, clinicians can better tailor treatment plans and set realistic expectations for patients, ultimately improving care quality. Osteoporotic vertebral compression fractures, or OVCFs, affect about 1.5 million Americans each year, primarily impacting the elderly. These fractures can result from trauma, malignancy, infection, but most commonly osteoporosis. Risk factors include advanced age, female gender, long-term steroid use, low estrogen, and certain lifestyle factors. Symptoms range from back pain and spinal deformity to neurological deficits, often leading to reduced mobility and increased mortality. While some fractures heal with conservative management, others require surgical intervention, like kyphoplasty. Kyphoplasty involves inserting a balloon into the fractured vertebra to restore its height, followed by injecting bone cement to stabilize the bone and relieve pain. This minimally invasive technique has become a mainstay for treating OVCFs, offering rapid pain relief and improved mobility. However, the procedure's effectiveness and complication rates may vary depending on whether it's performed in the thoracic or lumbar spine, due to anatomical and biomechanical differences. Compare outcomes. Researchers conducted a systematic review and meta-analysis, searching databases like PubMed, EMBUS, Ovid Medline, and Web of Science. They included studies where patients underwent kyphoplasty for osteoporotic fractures in either the thoracic or lumbar spine, and where clinical outcomes were reported by region. The review followed PISMA guidelines and used the ROBI and SI tool to assess risk of bias, ensuring a rigorous and transparent approach. Literature search yielded 1,164 results, which were screened for relevance and quality. After removing duplicates and applying strict inclusion criteria, 25 manuscripts were selected for final analysis. These studies spanned from 2003 to 2023 and included both retrospective and prospective designs, ensuring a broad and representative sample of kyphoplasty outcomes in both spinal regions. Included studies covered a diverse patient population, primarily elderly individuals with osteoporotic fractures. Both thoracic and lumbar cohorts were represented, with some studies focusing exclusively on one region and others including both. This diversity allowed for a robust comparison of outcomes and helped ensure that findings would be applicable to a wide range of patients. Researchers assessed a variety of perioperative and postoperative outcomes, including operative time, cement volume injected, pain relief, measured by the visual analog scale, or VAS, vertebral height restoration, kyphotic angle correction, and complication rates such as cement leakage and adjacent level fractures. By analyzing these outcomes separately for thoracic and lumbar procedures, the study aimed to uncover any meaningful differences. A notable finding was that kyphoplasty in the thoracic spine generally took longer than in the lumbar spine. The meta-analysis showed an average operative time of 56.4 minutes for thoracic procedures versus 43.1 minutes for lumbar ones. This difference may be due to the anatomical complexity of the thoracic region, including smaller pedicles and the presence of ribs, which can make the procedure more technically challenging. Amount of cement injected during kyphoplasty was slightly lower in the thoracic spine, 4.25 ml, compared to the lumbar spine, 4.61 ml. This likely reflects the smaller size of thoracic vertebrae. However, the difference was minimal, suggesting that surgeons generally use similar cement volumes regardless of spinal region, aiming for optimal stabilization and pain relief. Pain relief, as measured by the visual analog scale, was a central outcome in the analysis. Both thoracic and lumbar kyphoplasty patients experienced significant reductions in pain scores postoperatively. The average decrease was 5.49 points for thoracic and 5.59 for lumbar procedures, indicating that kyphoplasty is highly effective for pain management in both regions with no clinically significant difference. Restoring vertebral height is a key goal of kyphoplasty. Studies found that both thoracic and lumbar procedures achieved substantial improvements in anterior, middle, and posterior vertebral body height. Some studies noted slightly greater restoration in the thoracic spine, but overall, both regions benefited significantly, helping to correct spinal deformity and improve function. Kyphotic angle correction, which refers to the straightening of abnormal spinal curvature, was also assessed. Results showed that both thoracic and lumbar kyphoplasty led to meaningful reductions in kyphotic angle, with some studies reporting slightly greater correction in the thoracic region. This improvement contributes to better posture and reduced pain for patients. Cement leakage is a known complication of kyphoplasty. The meta-analysis found a higher average rate of cement leakage in the thoracic spine, 19%, compared to the lumbar spine, 13%. However, the overlap in confidence intervals suggests this difference may not be clinically significant. Anatomical factors, such as the shape of the posterior vertebral wall, may contribute to the higher leakage rate in the thoracic region. Another complication assessed was the occurrence of subsequent adjacent level fractures after kyphoplasty. The pooled proportion was 10% for thoracic procedures and 5% for lumbar ones. While the thoracic region showed a higher rate, the difference was not statistically significant. Factors like biomechanical stress redistribution and cement leakage may play a role in these outcomes. Review carefully assessed the risk of bias using the ROBINSI tool. Nearly half of the included studies were rated as having a serious risk of bias, mainly due to confounding variables. This highlights the need for more rigorous, controlled research to draw definitive conclusions about regional differences in kyphoplasty outcomes. Forming kyphoplasty in the thoracic spine presents unique technical challenges. The presence of ribs, smaller pedicles, and increased spinal curvature can make needle placement and balloon inflation more difficult. These factors may contribute to longer operative times and a slightly higher risk of complications in the thoracic region. Despite anatomical and technical differences, kyphoplasty remains a safe and effective treatment for osteoporotic compression fractures in both the thoracic and lumbar spine. The comparable outcomes in pain relief, vertebral height restoration, and complication rates support its use across both regions, allowing clinicians to confidently recommend the procedure based on individual patient needs. Selecting the right patients for kyphoplasty involves considering factors like age, comorbidities, fracture severity, and spinal region. Surgeons should counsel patients on the expected benefits and risks, emphasizing that outcomes are generally similar regardless of whether the fracture is in the thoracic or lumbar spine. This helps set realistic expectations and supports shared decision-making. Review acknowledges several limitations, including variability in study design, sample sizes, and kyphoplasty techniques. Many studies did not directly compare thoracic and lumbar outcomes within the same cohort, and there was substantial heterogeneity in reporting methods. These factors limit the generalizability of the findings and underscore the need for more standardized research. Future studies should stratify patients by spinal region and use standardized outcome measures to better understand the impact of anatomical and biomechanical differences. Prospective, controlled trials comparing thoracic and lumbar kyphoplasty within the same study population would provide more definitive evidence and help refine treatment guidelines. Summary: kyphoplasty offers comparable outcomes for osteoporotic compression fractures in both the thoracic and lumbar spine. Pain relief, vertebral height restoration, and complication rates are similar, despite some technical challenges in the thoracic region. These findings support the broader adoption of kyphoplasty across spinal regions and highlight areas for further investigation. Patients: the real-world impact of kyphoplasty is significant. Most experience rapid pain relief, improved mobility, and a better quality of life. The procedure's minimally invasive nature means shorter hospital stays and faster recovery, making it an attractive option for elderly patients with osteoporotic fractures. While kyphoplasty is generally safe, clinicians should remain vigilant for complications such as cement leakage and adjacent-level fractures. Early detection and management of these issues are crucial for optimizing patient outcomes. Understanding the anatomical nuances of each spinal region can help reduce risks and improve procedural success. Surgeon experience and technique play a vital role in kyphoplasty outcomes. Familiarity with the anatomical challenges of each spinal region, careful patient selection, and adherence to best practices can minimize complications and maximize benefits. Ongoing training and knowledge sharing are essential for maintaining high standards of care. Educating patients about the procedure, expected outcomes, and potential risks is key to successful recovery. Providing clear information and ongoing support helps patients feel empowered and engaged in their care, leading to better satisfaction and adherence to post-procedure recommendations. Recent advances in kyphoplasty, such as improved imaging guidance and new cement formulations, continue to enhance safety and effectiveness. These innovations may help further reduce complication rates and improve outcomes, especially in anatomically challenging regions like the thoracic spine. Optimal management of osteoporotic compression fractures often involves a multidisciplinary team, including orthopedic surgeons, radiologists, physical therapists, and primary care providers. Collaborative care ensures comprehensive assessment, appropriate intervention, and effective rehabilitation, maximizing patient outcomes. As the population ages, the burden of osteoporotic fractures will continue to grow. Ongoing research is needed to refine kyphoplasty techniques, identify patient subgroups who benefit most, and develop strategies to prevent complications. Future studies should focus on direct comparisons between spinal regions and long-term outcomes. Conclusion: kyphoplasty is a valuable treatment for osteoporotic compression fractures in both the thoracic and lumbar spine. The procedure offers significant pain relief, restores vertebral height, and has a manageable risk profile. While some technical challenges exist, especially in the thoracic region, outcomes are generally comparable. As research evolves, clinicians can continue to refine their approach and provide the best possible care for patients with spinal fractures.